Why is healthcare insurance such a mess in the United States? Well, we're going to talk a little bit about Chapter 6 today in a micro lesson. And really, there are two quick, big answers. One is we have a public and private blended method of health insurance, and some people have no insurance in the United States. And the other one is we, a long time ago, decided everything should be tied to the employer. So let's talk about this for a little bit. As you remember from Chapter 3, it wasn't until 1929 that there was any kind of real formal health insurance plan. It was in 1929 when Baylor University started a plan for the teachers there, and that led eventually to the Blue Cross plans that we're familiar with today. And really, that led to the bigger movement of having employer-based health insurance. But if we go back before that, there was some insurance. There was workers' comp, remember, from 1910, 1915 era. And even back then, people talked about, hey, if we can get this passed for the workers, maybe we can get some kind of universal health plan passed. Now, a lot of your friends, or even some of you may say, why don't we just adopt the same system that basically all but 5 or 6 countries in the world have, which is a government health insurance plan? Well, the reality is it's not quite that simple, and there's a lot of variability, as some of you may find out. I think a couple of you are actually researching this. Even the way that government plans are implemented is different. So let's go back to the public and private differences. Did you know that even in this country, up until really almost until the 60s, some of the large teaching hospitals had separate public and private clinics? And if you were to wander around some of the big teaching hospitals in the United States, in the older buildings, you would actually maybe even find some old signs, and you'd see where they used to have a separate clinic for the people that had insurance, the people that had money, and the people who didn't. A lot of people kind of found this to be unethical, and so people reacted to that. And interestingly enough, it wasn't until 1970 that we got something called EMTALA, which is the Emergency Medical Treatment Act, which required people to stabilize anyone who came to the emergency room. A lot of us think if we go to the emergency room, they have to take care of us, but actually, all they have to do, according to the federal law, is make sure that you're removed from your emergency crisis, and then they can transfer you to another hospital. So we've long been plagued by this challenge of even within our own system having multiple payer sources. Any of you who work for a provider know this. And I'd also point out that most industrial systems have some kind of cash element. There's always that option of you going straight to the doctor and paying cash. I did some work in Eastern Europe right after the wall fell, and one of the problems we had there, even under communism, when they had quote unquote 100% universal coverage, you always took money to the doctor. You paid the doctor, they call it under the table payments. You basically pass the money to the physician, and then you would get your treatment, you get your prescription. And even when I was there in 2000, so 10 years after the wall fell, 50% of physician payments were cash, okay? And we were concerned that they were not all, these weren't copays. These were people bringing in money to sort of pay off the doctor. So we've long had a challenge with that. And even in Canada and in England, there's a separate avenue. So we have this issue where health insurance is tied to the employer. Even people who you would think, well, hey, as long as you're employed, you're in good shape. Well, then people are tied to the actual plan that their employer picked. And sometimes the person choosing that plan may be someone who doesn't have a lot of healthcare experience. In fact, most of you probably have more healthcare appreciation than they might. So this is a challenge we continue to have. And I think on top of that, we also have we have two things going on. There is that American will that we want everyone to have. We want things to be fair, and that usually helps us when we're looking at trying to make things equitable. But on the other hand, we also have that sort of I want mine personality of the American way. Like basically, I earned it, so I want it, which kind of stands in the way when we ever talk about rationing healthcare. If I come talk to you about your family member, or if let's say you've just had your first child and the physician comes in and says, hey, we have this treatment for you, but it only works 10% of the time and it's very expensive. You're probably going to say, I want it, right? I mean, I would want that for my own child. And this is really what happens sometimes when people try to do what we call healthcare rationing. And there was a big experiment with this in the 90s in Oregon, where Medicaid tried to make a list of all the most efficacious healthcare treatments, and they ranked them, and then they just weren't going to pay for the bottom ones, and people reacted to that and said it wasn't good, and so that also stands in the way. So when you hear about the Affordable Care Act, and however you feel about it being repealed, or some of those things being increased, or if you hear about people talking about universal health care, just step back for a minute and think to yourself, how did we get here? How did we get into this mess? And what is uniquely American about that mess? Uh, and I hope that as you read further, you'll think about this some more. Again, this is Why is Healthcare Such a Mess? And it's kind of an intro to Chapter 6. And we are in U.S. Healthcare System, HCM 300, Jefferson College of Health Sciences. Thank you.